Anesthesia for joint replacement surgery. Now, these are the learning objectives that we will be covering in this talk. Now, with the aging population, there is an increased demand for joint replacement surgeries. Joint replacement is a common and effective procedure for relief of disability due to severe joint pain and loss of function. The most common joints replaced are the hip, knee, and shoulder joints. Most patients of joint replacement, they have generalized degenerative joint disease such as osteoarthritis. Other conditions necessitating joint replacement, they are rheumatoid arthritis, osteoporosis and fracture, metastatic lesions and pathological fracture, ankylosing spondylitis, and AVN. Now, what is arthroplasty? It is a reconstructive surgery to restore the joint motion and function and to relieve pain. It generally involves the replacement of the bony joint structure by the prosthesis. Most patients presenting for joint replacement surgery, they are elderly with multiple medical problems. The mortality after hip and knee arthroplasty ranges from 0.4 to 4.6% depending on the type of surgery, whether it is a primary or a revision surgery. Now, the pre-operative issues. Pre-operative optimization is mandatory as the chances of serious complications within 30 days of joint replacement is 2.2%. In addition to the established protocol for the age and comorbidities, an elaborate pre-anesthetic checkup is needed. Problems in multiple systems are common because most of these patients are of geriatric age group. The pre-operative assessment involves history, which is very important. Now, this will involve the personal history, which will take into account the current problems and activity. What type of patient are we dealing with? The young, old, active, inactive, or a lucid patient. The personality, age, and activity dictate the type of anesthesia. Patient's vitals have to be noted, such as the age, weight, BMI, and the vital signs such as blood pressure, heart rate, pulse rate, respiratory rate, and temperature. Drug history is very important in these patients because they may be on multiple drug therapy such as warfarin, aspirin, or NSAIDs. These drugs have side effects of GI bleeding, renal toxicity, and platelet dysfunction, which may be important in terms of neuroaxial block. Some patients may be on immunosuppressants and steroid supplementation may be required. Elderly patients may be on beta blockers or ACE inhibitors. Allergies. You inquire about the specific antibiotic allergies and check for the type of cement being used. Aseptic loosening of the cemented THR has been linked to allergies of some component of the cement. Surgical history, a history of previous anesthesia. The anesthesia record may indicate any difficulty if somebody has encountered in spinal and epidural, airway assessment with intubation and other problems. Family history, history of any inherited disorder such as hemophilia. General examination, the BMI and shape of the back may determine the type of anesthesia to be used. Pallor, dehydration, and edema will alert the need for further evaluation. Now, there are two main types of arthritis these patients suffer from, the osteoarthritis and the rheumatoid arthritis. Osteoarthritis is the most common type. It is loss of articular cartilage and inflammation. It may manifest itself clinically in the form of pain, crepitus, decreased mobility, and deformity of the hands. In hands, there may be spurring, there may be Herberdin nodes, that is swelling of the distal interphalangeal joint, and the proximal interphalangeal joint in the form of Bouchard's nodes. There are however, no systemic manifestations of this disease. Only limited mobility and difficulty in positioning for surgery and anesthesia has to be noted. These are the areas which are common affected, and these are the Herberdin's and the Bouchard's node. Rheumatoid arthritis, it is a chronic inflammatory form of arthritis. It affects about 1% of the adults. It is most common in women than in men, and it is characterized by persistent joint synovial tissue inflammation leading to bone erosion, destruction of the cartilage, and loss of joint integrity. It is a systemic disease affecting multiple organ systems and often progresses through multiple exacerbations and remissions, present with pain and stiffness of multiple joints. The joint commonly involved, they are the wrist joint and the MCP joints, which distinguishes it from the osteoarthritis because the joints become boggy, tender, and warm. Subcutaneous rheumatoid nodules may surround the joints, extensor surfaces, and bony prominences. Airway management of these patients can be extremely challenging. TMJ synovitis limits the mandibular motion and the mouth opening. The arthritis, it damages the cricoarytenoid joint and causes decreased movement of the vocal cord and the narrowed glottic opening. During DL scopy, the vocal cords may appear erythematous or edematous. There is a reduced glottic opening which may interfere with the passage of the endotracheal tube. There is also increased risk of cricoarytenoid dislocation with traumatic intubation. Arthritis of the cervical spine, atlantoaxial subluxation, flexion of the head may cause displacement of the odontoid process into the cervical spine and medulla compression of the vertebral artery, but which may precipitate quadriparesis and may result into spinal shock and death. Preoperative cervical flexion and extension X-rays are required to plan for awake fiber optic intubation, and cervical spine should be protected with a collar. Now, these are the anesthetic considerations in the rheumatoid arthritic patients. The airway, there may be limited oral opening due to TM joint involvement and arthritis of the cervical spine. In the respiratory system, there may be a diffuse interstitial fibrosis and a pleural disease with intrapulmonary nodules. In heart, there may be restrictive pericarditis, pulmonary hypertension leading to right heart failure. In eyes, there may be drying of eyes with corneal and conjunctival lesions in Sjogren's syndrome. Drugs assess the GI effect and renal problems in patients taking NSAID. Glucocorticoids can have systemic side effect. Consider the need for additional dose during surgery, and disease-modifying anti-rheumatoid drugs may cause increased risk of infection with prosthesis insertion. Now, these are some of the extra articular manifestations of rheumatoid arthritis. These are the nodules we can see. So it usually affects the joint symmetrically and may initially begin in a couple of joints only, but may attack the wrist, hand, elbow, shoulder, knees, and the ankles. Ankylosing spondylitis. Now, this is a chronic inflammatory arthritic disease that results in fusion of the axial skeleton. There is ossification of the axial ligaments progressing from sacral-lumbar region cranially, resulting in loss of spinal mobility. There is also significant challenge with the general anesthesia because of the decreased movement of the cervical spine and the TM joint. In most cases, awake fiber optic endotracheal intubation is what is required in general anesthesia. Increased rigidity of the thoracic spine in most cases may also necessitate intraoperative controlled mechanical ventilation. Although neuraxial anesthesia is a better alternative to general anesthesia, ossification of the spinal ligaments may make it impossible. The extraskeletal manifestations of ankylosing spondylitis, they may be aortic insufficiency, cardiac conduction abnormalities, upper lobe fibrobulbous disease, and pleural effusion. Strict attention should be paid to positioning to avoid fracture of the fused spine and concomitant spinal cord trauma. Assessment of the comorbidities. Now, let us start with the cardiovascular system. This is estimated by the exercise tolerance, but it is nearly impossible because a limited exercise can be done in these patients. It can be, the MET classification can be done. 1 MET is when there is resting, eating, and toilet needs are met. 3 is with mild housework. 4 is 2-story climbing. 7 is heavy housework, and more than 10 is heavy sports ability. Patients with MET more than 4 are considered good in terms of functional capacity. Patients with hypertension. Adequate blood pressure control is essential pre-operatively, as this reduces the perioperative ischemia and consequent cardiac morbidity. Antihypertensive drugs should be continued throughout the perioperative period, except diuretics and angiotensin converting enzyme inhibitors. Abrupt withdrawal of beta blockers may precipitate myocardial ischemia by adversely affecting the heart rate and the blood pressure. The ECG can identify ischemia and arrhythmia, and for more complex cardiac disease, the ECG can provide additional information on ventricular function and valvular abnormalities. The echo, however, can provide about LV function, wall motion abnormality, and the wall abnormality. Now, patients on an pacemaker, that is the implanted cardiac device. Adenosine radionuclide imaging is used in these patients with a pacemaker, as the dobutamine stress testing is not possible. This technique uses the vasodilatory properties of adenosine and the uptake of the radioisotope by a viable myocardium. Patients with permanent pacemakers who are pacemaker dependent should have their device evaluated within 3 to 6 months before significant surgical procedure and also after the surgery. A 10% decrease in the rate from the time of implantation indicates a power source depletion. American College of Cardiology and the American Heart Association guidelines advise that an implanted cardioverter defibrillator, that is the ICD, should be reprogrammed to a monitor-only mode to prevent inappropriate shock delivery caused by electrical interference. Temporary pacing equipment and a cardiologist along with a magnet should be available intraoperatively. Normothermia should be maintained during the perioperative period as shivering may interfere with the functioning of the device. Patients with the coronary artery disease. Patients with a history of recent myocardial infarction, unstable or severe angina, decompensated heart failure, severe valvular disease such as aortic stenosis, or significant arrhythmias, example ventricular tachycardia or atrial fibrillation, with a rapid rate, they are not fit to undergo joint replacement. Beta blockers are continued through till the day of the surgery, and in patients who have undergone percutaneous coronary intervention or arthroplasties should be delayed for a period of 14 days for balloon angioplasty, 4 to 6 weeks for bare metal stent, and 1 year for drug-eluting stents. Clopidogrel, ticlopidine, and GP2A and 2B and 3A inhibitors should be discontinued 7 days, 14 days, and 8 to 48 hours respectively before the scheduled surgery. The patient should be assessed for the risk of stent thrombosis before stopping the dual antiplatelet therapy. In selected cases, bridging therapy with heparin or tirofiban or heparin ftipabide may be considered. Perioperative anticoagulation with a low molecular weight heparin provides incomplete protection against stent thrombosis. Therefore, the dual antiplatelet therapy should be restarted as soon as possible. Now, patients on anticoagulants. Patients on oral anticoagulation may require bridging therapy perioperatively depending on the risk of thromboembolism. Conditions with a high risk for thromboembolism where bridging is advised includes patients with thrombophilia, recurrent, that is 2 or more recent within 3 months thromboembolic events, atrial fibrillation with a risk factor for embolism, or a recently placed mechanical valve less than 3 months. Bridging decision may be individualized in patients with the intermediate risk for thromboembolism. The bridging therapy, warfarin should be stopped 5 days before the surgery if an INR is 2 to 3 and 6 days if INR is 3 to 4.5. The low molecular weight heparin should be started 36 hours after the last warfarin dose. Choice of low molecular weight heparin may include enoxaparin, which is 1 mg per kilogram, twice daily, or 1.5 mg per kilogram once daily. The last dose of low molecular weight heparin should be given 24 hours before the planned surgery. Preoperative INR should be less than 1.5. Postoperatively, the warfarin is started on the evening of the surgery and the low molecular weight heparin should be restarted after 24 hours. Low molecular weight heparin is discontinued when INR is therapeutic for 2 consecutive days. The platelet count should be checked on the 3rd and 7th day for the possibility of thrombocytopenia. Now, the renal system. They may be impaired due to hypertension or chronic use of NSAIDs. Prerenal azotemia is corrected with hydration. Patients with elevated body mass index, elevated preoperative serum creatinine, history of chronic obstructive pulmonary disease, liver disease, congestive heart failure, hypertension, and underlying heart disease, they are at high risk for developing post-operative derangement of the renal functions. Patients with chronic kidney disease have normochromic normocytic anemia. Therefore, pre-operative correction should be done. The platelet count is within normal limit, but the platelet activity is abnormal, which can be improved by dialysis. Dobutamine stress echocardiography should be done in the CKD patients for assessment of the cardiac status. Adenosine stress testing is not reliable in view of the maximum vasodilatory state. Optimal fluid therapy can be guided by CVP monitoring, and lactate containing fluids should be avoided. Perioperative cover with broad spectrum antibiotics is essential in view of the impaired immunity. Patients on renal replacement therapy should have their dialysis scheduled 24 hours before surgery. Musculoskeletal. Other joint involvement is also very common. The range of limb and neck movement should be noted. Obesity may be a cause or a consequence of a degenerative joint disease. Assessment for positioning on the table and for the neuroaxial block should be done. Neurological assessment. As most of these patients are geriatric patients, they may have weakening of memory, decrease in cognitive and intellectual functions, diminished movements, deterioration of sleep cycle, decrease in visual, acoustic, taste and smell sensation, imbalance of autonomic nervous system, Parkinson's, depression or dementia. In the respiratory system, patients with COPD and chronic smokers, they benefit with pre-operative physiotherapy and spirometry. The incidence of post-operative pulmonary complication is about 25 to 90% if FEV1 is less than 65% and the risk of complication is more than 50%. PaCO2 more than 45 millimeter of mercury is a strong risk factor for pre-operative pulmonary complications. American Thoracic Society and the European Respiratory Society in 2004 have provided guidelines for perioperative management of patients with COPD. Patients with a diagnosis of COPD, they have a 2.7 to 4.7 fold increased risk of postoperative pulmonary complications. Smoking cessation at least 4 to 8 weeks operatively and optimization of lung function can decrease the postoperative complications. In patients with COPD, preoperative spirometry should be performed. Arterial blood gases is needed in moderate to severe COPD patients. Bronchodilators, inhaled or oral steroids and antibiotics have to be continued till the day of the surgery. Beta agonists are more useful prophylactic intervention to lower the risk of bronchospasm on induction. Now, diabetic patient. A preoperative evaluation includes assessment of the metabolic control and any diabetes associated complications, including cardiovascular disease, autonomic neuropathy and nephropathy. Stress test is mandatory to know about the functional status of the heart. The autonomic dysfunction, which is usually caused by diabetes in long term, is an important factor for regional anesthesia and for control of perioperative hemodynamic instability. There is a possibility of a silent myocardial infarction. Oral antibiotics should be stopped at least 24 hours before surgery and they should be switched over to insulin. Nutritional control. As most of these patients are geriatric, the nutritional status should be evaluated. It can be assessed by the mini nutritional assessment test. If albumin is less than 3.5, supportive treatment should be given. Decreased GFR due to age should be considered. Urea, serum creatinine and electrolytes should also be noted. Now, a small say about an oncological patients. Systemic evaluation of the oncological patients is very important. The patient should be inquired about radiotherapy and chemotherapy. In these patients, impaired health status and blood volume changes due to bone marrow suppression may be there. Alkylating agents like cyclophosphamide may prolong the neuromuscular block. Vascular access may be difficult. Pre-operative nutritional support should be given. Immunonutrition is thought to be useful to decrease the immunosuppression. Long metastasis may impair the respiratory function. In hepatobiliary system, deterioration of LFT may be there. Decrease in coagulation factor and coagulopathy is seen with hematopoietic system. In urinary system, radiation nephropathy can be there. And so a multidisciplinary examination of a cancer patient should be done. The investigations which are needed before a joint replacement are CBC, serum creatinine and electrolytes, ECG and echo, chest X-ray, coagulation profile, blood glucose, urine analysis, because urinary tract is a potential reservoir of resistant pathogens for joint infection. UTI has been identified as a predictor for periprosthetic joint infection. Dental checkup is also recommended in some cases to rule out any infection in the body. MRSA. Pre-operative testing of the nasal swab for MRSA can be done routinely to decrease the Staph aureus surgical site infection. Studies have found that nasal screening and decolonization with nasal mupirocin twice daily for 5 days prior to surgery resulted in a 4-fold decrease in the Staph aureus surgical site infection. Preoperative preparation. Now, this involves the proper assessment, optimization of comorbidities, DVT prophylaxis, antibiotic prophylaxis. Invasive monitoring seldom needed, and a large bore cannula is required. Now, let us look at the intraoperative issues. First is the DVT and the thromboprophylaxis. DVT and pulmonary embolism is one of the leading causes of morbidity after orthopedic surgery. Short-term complications of survivors of acute DVT and pulmonary embolism are prolonged hospitalization, bleeding complications leading to DVT or pulmonary embolism treatment. The long-time complications are post-thrombotic syndrome, pulmonary hypertension, or recurrent DVT. The incidence of DVT is 40 to 50% without any prophylaxis, and the incidence of pulmonary embolism is 20% with a fatality rate of 1 to 3%. Now, what is the pathogenesis? It is the virtuous triad, that is the venous stasis, vascular injury, and the hypercoagulability. When they occur together, they increase the risk of clot formation. The risk factors are obesity, age more than 60 years, procedure more than 30 minutes, use of tourniquet, lower extremity fracture, and immobilization more than 4 days. It can be prevented by a non-pharmacological method and the pharmacological method. Non-pharmacological is intermittent pneumatic compression, and IVC filter in patients contraindicated for anticoagulation. Pharmacological is warfarin, low molecular weight heparin, and heparin. The recent drugs are the fondaparinux and the dabigatran. Now, the treatment may be anticoagulant or thrombolytic. If it is a venous thrombi, it may result in fibrin thrombi, so anticoagulation for treatment and prevention. If there is a severe, possibly fatal pulmonary embolism, then thrombolytics are what is requirement. Based on the guidelines based by the American College of Chest Physicians, patients undergoing elective total hip or knee replacement should receive one of the following prophylaxis. The low molecular weight heparin is started 12 hours before surgery or 12 to 24 hours after surgery. The warfarin is started pre-operatively or the evening of the surgical day with target INR of 2.5 and the range between 2.2 to 3. The fondaparinux 2.5 milligram is started 6 to 24 hours after surgery. Use of intermittent pneumatic pump can be an alternative option. The optimal duration of therapy is unknown, but from 10 days to 35 days is what is recommended. Then monitoring, non-invasive monitoring is what is generally used. Invasive may be needed when there is a lot of comorbid condition or where an extensive blood loss is expected. Antibiotic, usually a second or third generation, is given at the end of at the induction of the anesthesia. Positioning. It is very important to know the various implications of the patient positioning during surgery because of the various physiological effect it exerts on the system. The goal of the surgical positioning should be to facilitate the surgery and to balance the risk factor. Positioning is important for patient safety to prevent the nerve injuries, enable the IV access, endotracheal and catheter to remain patent, proper monitoring. The positions are supine is for the TKR, lateral for THR, and beach chair position for the shoulder replacement surgery. Now the lateral position. Now this position can compromise the oxygenation, especially in the obese and severely arthritic patients due to the VQ mismatch. A pad is placed under the head, so it is in neutral position. The arm is placed perpendicular to torso, whether on a pillow or over an armrest. A pillow is placed between the legs. Care is taken by padding to prevent the pressure on the ulnar nerve at the elbow or radial nerve at the radial groove. A higher chest exposure may be required in lateral position, and in this the arm is kept in more anterior plane to the body to prevent stretching of the brachial plexus. Supine, it is the commonest position and it is used for TKR. The pressure points have to be protected and the arms are tucked, and if arms are on the arm boards, they should be at less than 90 degrees and the arms are supinated and the padding is placed below the elbow. Now beach chair position, it is used for shoulder surgery. It provides both anterior and posterior access to the shoulder. It provides a freely mobile upper limb and can be associated with neurological injuries, cervical neuropraxia, and hypotensive bradycardia. The endotracheal tube should be well secured and the neck should be well supported. Now, blood loss and fluid management. Blood loss is estimated to be around 300 to 500 ml for THR, but more in revision arthroplasties. Careful fluid replacement is critical because compensation for hypovolemia is poor in elderly patients. A cell saver can be used when a significant blood loss is anticipated to reduce allogenic blood transfusion. Other blood conservation techniques such as autologous pre-donation, controlled hypotension, as well as avoidance hypothermia is done. In TKR, use of tourniquet may offer a bloodless feel, which becomes apparent when the tourniquet is deflated. Careful monitoring of the drain output and the blood loss in the recovery is recommended in these patients. Hypothermia, active warming of the patient decreases the blood loss and the associated morbidities. Hemostatic mechanism is also reduced in the elderly patient. Now, one of the common complications is the bone cement implantation syndrome. The bone cement is polymethyl methacrylate, is an acrylic bone cement used for commonly in joint replacement surgery. The cement binds to the cancellous bone and thus binds the prosthesis to the patient's bone. To make the cement, the liquid methyl methacrylate is mixed with the polymerized methyl methacrylate powder. It is an exothermic reaction. The bone cement syndrome is characterized by hypotension, hypoxia, and sometimes loss of consciousness. It occurs at the time of cementation and insertion of prosthesis, reduction of the joint, and occasionally tourniquet deflation in a patient undergoing cemented bone surgery. It can be classified into grade 1, 2, and 3. 1 is when the hypoxia is less than 94%, fall in systolic blood pressure less than 20%, and the patient is conscious. Second is when there is a severe fall in SpO2 less than 88%, systolic blood pressure more than 40%, and loss of consciousness is there. And in the grade 3, there may be a cardiovascular collapse requiring cardiopulmonary resuscitation. The risk factors for bone implantation syndrome, they may be patient-related or surgery-related. When there is a high BMI, more than 30 kg per meter square, poor physical reserve, impaired cardiopulmonary function, or osteoporosis pathological fracture. The surgery-related factors, they may be previously uninstrumented femoral canal and a long stem femoral component. Now, what is the pathophysiology of it? It is not fully understood, but several mechanisms have been proposed for it. During surgical cementation and prosthesis insertion, the cement is intentionally pressurized to force it into the intricacies of the bone, ideally improving the bonding between the cement and the bone. The cement then expands in the space between the bone and the prosthesis, further pressurizing air and the medullary contents and potentially forcing them into circulation. These embolic contents include the fat, marrow, cement, air, bone particles, and aggregates of platelets and fibrin. When these debris emboli, they reach the lung, heart, and or coronary circulation. It is hypothesized that shower of pulmonary emboli are the cause of characteristic hypoxia and right ventricular dysfunction or bone cement implantation syndrome, leading to hypotension. These physiological changes from embolization can be attributed to both the mechanical effect of the emboli and the mediator release, which provokes the increased pulmonary vascular tone. Second is the systemic absorption of the residual methyl methacrylate, that is the histamine release, hypersensitivity, and complement activation. It is felt that the embolic model alone cannot account for all the features of BCIS, and that a combination of different factors acting in tandem contributes to a full clinical picture which can be seen. Anaphylaxis and BCIS share many features, notably an increase in the plasma histamine concentrations. Surgeons in frequent contact with the common cement used, that is the methyl methacrylate, have found to have an increase in the blood level of C3AA and C5A. These are anaphylactoid components and they are potent mediators of vasoconstriction and bronchoconstriction. Collectively, it is felt that these mediators yield an increase in the pulmonary vascular resistance, causing a ventilation perfusion disturbance, hypoxia, right ventricular failure, and a cardiogenic shock. Now, what are the clinical manifestations? It may be hypoxia due to increased pulmonary shunt, hypotension, arrhythmias including heart block and arrest, pulmonary hypertension, increased pulmonary vascular resistance and dyspnea, decreased cardiac output, and an increase in the ETCO2. Treatment is you increase the FiO2 prior to cementing, euvolemia prior to cementing, creating a vent hole in the distal femur to decrease the intramedullary pressure, a high pressure lavage to decrease the debris, and use a cementless prosthesis. The cementless implants, they are made of porous materials and they have the advantage of natural bone going into it. They last longer, so they are preferred in young patients. Now, pneumatic tourniquet. Now, this is used in the TKR to create a bloodless field, but the pressure can be above 100 millimeter above the systolic blood pressure, but it should not be for more than 2 hours. More than 2 hours, it causes transient muscle dysfunction, rhabdomyolysis, and nerve injury. The advantage are bloodless field, while the disadvantage are the nerve injury, muscle damage, and the systemic effect of inflation and deflation. Now, what happens with the inflation is there may be pain, sympathetic stimulation, hypertension, tachycardia, and diaphoresis. If more than 2 hours, transient muscle dysfunction, rhabdomyolysis, and permanent damage can occur, and fold of tourniquet can cause skin bruising. With deflation, there may be increase in the PCO2, potassium, and lactate, increase in minute volume in spontaneously breathing patient, transient metabolic acidosis, and the core temperature decreases. Now, what is the safety relation between the limb occlusion pressure and safety margin? If it is less than 130, the safety margin is 40. Between 131 to 90, the safety margin is 60. And more than 190, the safety margin is 80. How do you prevent these complications of tourniquet? Is proper selection of patient, wide low pressure cuff, apply the lowest pressure needed to prevent bleeding, do not exceed more than 2 hours, maximum pressure in the arm 50 to 75 millimeter above systolic, and in the legs 75 to 100 above systolic, and adequate padding should be there. Now, fat embolism syndrome. Now, it is a well-known complication of instrumentation of the medullary canal. The risk factors are the male gender, age 20 to 30 years, hypovolemic shock, intramedullary instrumentation, rheumatoid arthritis, THR, and a bilateral TKR. Now, let's look at the pathogenesis to it. Two theories are hypothesized to explain this, the mechanical theory and the biochemical theory. The mechanical theory proposes that the long bone trauma results in the release of fat droplets that enter the vascular system through the torn veins. These droplets are transported through the pulmonary vascular bed as microemboli. In the biochemical theory, it can be divided into two mechanisms, the toxic and the obstructive. The toxic mechanism proposes that the free fatty acids released at the time of trauma directly affects the pneumocytes in the lung and causes ARDS. This effect would be enhanced by the trauma-induced release of catecholamine, which would result in further mobilization of fatty acids. The obstructive theory hypothesis that an unspecified chemical event at the site of the fracture releases mediators that affect the lipid solubility, resulting in coalescence of lipids and consequent hydrolyzation. The clinical manifestations of Fat embolism syndrome, they may be agitation, confusion, stupor, and coma, thrombocytopenia or a prolonged clotting time, cutaneous petechial hemorrhages, mild hypoxia, respiratory failure, ARDS, and persistent tachycardia and hypotension. The clinical signs have been classified by GERD as major or minor, with the diagnosis requiring at least one major and four minor criteria, as well as exclusion of other post-traumatic causes of hypoxemia. The major features are respiratory insufficiency, that is PO2 less than 60 millimeter of mercury, cerebral involvement, altered mentation, and petechial rashes. The minor, which is pyrexia, tachycardia, retinal changes, jaundice, and renal changes. And the lab findings may have fat microglobulinemia, anemia, thrombocytopenia, and a high ESR. A petechial rash is pathognomonic of fat embolism syndrome, with the rash is usually present in the conjunctiva, oral mucosa, and skin fold of neck and axilla. This is shown by the Schoenfeld Fat Embolism Index, which ranks the signs and symptoms of FES in relation to the incidence of preparation. The signs may be petechial rashes, diffuse alveolar infiltration, infiltrates, hypoxemia, PaO2 less than 70, confusion, fever more than 38, heart rate more than 120 beats per minute, and respiratory rate more than 30 minutes. A score of more than 5 is required for diagnosis of FES. Now, how do you diagnose this fat embolism syndrome under GA? There may be a decrease in the EtCO2, decrease in the arterial oxygen saturation, increase in the pulmonary artery pressure, and right-sided heart strain and ischemic changes in the ECG. Treatment may be prophylactic or it may be supportive. Prophylactic is early resuscitation and stabilization to minimize the stress response, hypoxemia, hypotension, and decreased organ perfusion. Patients at risk should be monitored with pulse oximetry and ventilated before the respiratory failure ensues. Supportive is oxygen therapy with CPAP, invasive monitoring for volume status and use of inotropes, vasodilators for pulmonary hypertension, and high dose of steroid. Now let us look at the anesthetic technique. Various anesthetic techniques such as general anesthesia, regional anesthesia with neuroaxial block, peripheral block, or a combination of two can be used for hip, knee, or shoulder arthroplasties. Antifibrinolytic agent like tranexamic acid is recommended for reducing the intraoperative blood loss in patients who are not at increased risk of thromboembolic event. Tranexamic acid is given as an intravenous infusion of 20 mg per kilogram at the time of the skin incision. General anesthesia, if general anesthesia is indicated, bleeding may be decreased by using a hypotensive anesthesia. For hip arthroplasties, the analgesia can be supplemented by using a 3-in-1 block. Hypotensive anesthesia in selected group of patients gives the advantage of reduced tourniquet time, blood loss, and the need for transfusion. GA has the advantage of better hemodynamic control. Since most of these procedures are in geriatric patients, pre-medication which depresses the respiration should be avoided. When performing volume replacement, cardiac load should be avoided and the mean arterial pressure has to be maintained. Respiratory depression should be avoided by titrating the opioid dose, and the renal function should also be preserved. Regional anesthesia, spinal or epidural anesthesia can be used for both hip and knee replacement. It has the advantage of early mobilization, better pain relief, reduced risk of DVT, hypoxia, and conscious problem. Further, it is more cost effective and easy to perform. Disadvantage is that special care has to be taken with anticoagulants. A plan specific to each patient of anticoagulation and the anesthetic technique has to be chalked out. The ASRA has come up with advisory guidelines for neuroaxial anesthesia and antithrombotics. So if warfarin is used, you stop 4 to 5 days prior to the block, confirm the INR. The catheter should be removed when INR is less than 1.5 and removal with INR between 1.5 to 3 minutes, close neuromonitoring. And warfarin should be held if INR more than 3. Aspirin has no contraindication. Clopidogrel stop 7 days prior to the block, and if neuroaxial considered between 5 and 7 days, restoration of platelet function should be confirmed. Prasugrel stop 7 to 10 days days prior to neuroaxial block, wait 9 hours after block or catheter removal. Ticagrelor stop 5 to 7 days, wait 10 hours after neuroaxial block or catheter removal. Ticlopidine, stop 14 days prior to neuroaxial block. Dabigatran, stop 5 days prior to neuroaxial block, wait 6 hours after block or catheter removal. Apixaban, stop 3 days prior and wait 7 hours after neuroaxial block or catheter removal. Rivaroxaban, stop 3 days prior to block and wait 8 hours after neuroaxial block or catheter removal. Thrombolytics, fibrinolytics, and thrombin inhibitors, the neuroaxial techniques are contraindicated except in unusual circumstances. Heparin, the low molecular weight, preoperatively wait 10 to 12 hours after prophylactic dose, 24 hours after treatment. Post-operatively, catheter should be removed 2 hours prior to initiation of twice daily dosing regime. And for single dosing, catheter can be maintained but should be removed 10 to 12 hours after the last dose. Subcutaneous 10,000 units per can be given, and intravenous stop 2 to 4 hours prior to catheter removal. Wait 1 hour after neuroaxial block or catheter removal before administration of the drug. Peripheral nerve block, if neuroaxial block is contraindicated, the fascia iliaca block, femoral nerve block or a sciatic nerve block or lumbosacral block can be used for THR or TKR. For shoulder replacement, interscalene block may be used. These blocks can be given via nerve stimulator or an ultrasound guided block. There are various advantages and disadvantages of the peripheral nerve block. The advantage is quality of analgesia is equivalent to spinal and epidural anesthesia but superior to opioid, less chances of hemodynamic instability and urinary retention, and preservation of the contralateral limb strength, so it may facilitate post-operative rehabilitation. Drawback is nerve injury, post-block paresthesia, fall and injury, toxicity of local anesthetic, and retroperitoneal hematoma. Now let us look at the post-operative complications. Cardiac complication. The ACC-AHA guideline recommends pre-operative cardiac testing in patients at increased risk on the basis of clinical risk profile, functional capacity, and the type of surgery. Orthopedic surgery is an intermediate surgery. Older patients have an increased risk of perioperative myocardial morbidity and mortality after orthopedic surgery. This is because of the multiple medical comorbidities, limited functional capacity, significant blood loss, increased post-operative pain, initiation of systemic inflammatory response. So all this stress response leads to tachycardia, which causes hypertension, which causes an increased oxygen demand and increased risk of myocardial ischemia. In the respiratory system, the elderly patients show progressive decrease in the arterial oxygen tension, increase in the closing volume, and decrease of approximately 10% of the FEV1 with each decade of life. The chest wall mechanisms are exacerbated with arthritis. Hypoxia reflects respiratory changes caused by age or embolization of bone marrow debris in the lung of these patients. Neurological confusion and delirium may be seen postoperatively. This is associated with the increased length of hospital stay, poor functional recovery, progression to dementia, and increased mortality. The risk of delirium is increased because of advanced age, alcohol use, perioperative dementia, psychotropic medications, associated comorbidities, and perioperative events. Now, what are the strategies to decrease this? Is identify the risk factors, vulnerable and affected patients, preserve the orientation, early mobilization, adequate pain control, maintenance of normal sleep cycle, and avoidance of psychotropic medications. Post-operative urinary retention, the incidence is 10.7 to 84%. Routinely preoperative catheterization is not done in a lot of patients, but it is especially indicated in those patients who have prostatic symptoms. Popliteal vascular injury, this is a rare complication of the total knee arthroplasty, the incidence being 0.03 to 0.17%. Pre-existing arteriosclerotic disease, correction of extensive flexion contracture, and redo arthroplasty are identified as the risk factors. Vascular complications commonly seen are the thrombosis, atherosclerotic occlusion, or direct sharp trauma. Excellent limb salvage can be achieved with close post-operative surveillance to achieve early detection and repair of injury. Color Doppler flow ultrasound is safe and accurate method to confirm the diagnosis. Now, the post-operative analgesia. Best approach is the multimodal approach. It provides the benefit of multiple drug delivery system tailored to patients' needs with minimum side effects. Inadequate postoperative because inadequate postoperative pain management causes increased postoperative hospitalization and a decreased quality of care. The concept of multimodal analgesia relies on the understanding of neurohumoral interaction and achieving postoperative analgesia by using a combination of drug or modalities which inhibit the complex pathway at multiple sites and reduce the requirement and side effects of the individual drugs. The various analgesic options which are available are the epidural analgesia, which provides good pain relief after hip and knee surgery. The patients receiving epidural analgesia experience less pain as compared to patients receiving systemic analgesic. The removal of catheter, however, has to be balanced with the anticoagulation, and this method is very good for THR, where drug can be given as a continuous infusion of local anesthetic or local anesthetic with opioids, or a PCA pump can be attached. The lumbar plexus block can be blocked in three approaches: block of full lumbar plexus, that is femoral, lateral femoral cutaneous, and the obturator block, is accomplished with the posterior psoas block. The hip joint is innervated by the femoral, sciatic, and obturator nerve, with skin and superficial tissues receiving branches from the lower thoracic nerve. The posterior lumbar plexus block provides a better analgesia compared to the distal lumbar plexus block for THR. For knee joint, a femoral nerve block along with the sciatic nerve block can be used. The advantage of the femoral nerve block are limited by quadriceps paresis, which hinders the post-operative physiotherapy and immediate functional recovery. The sciatic nerve block, when added to the femoral nerve block, may improve the pain relief. Recently, an adductor canal block is an alternative to femoral nerve block. Ultrasound-guided adductor canal block is associated with significantly less analgesic consumption after TKR. Local infiltration for TKR is also a very good option. It is a part of multimodal pain management. The density of nerve ending is not homogeneous throughout the knee joint, but areas including the suprapatellar fat pad, collateral ligaments, meniscular capsule attachment, and the periosteum are particularly densely innervated. The local infiltration usually contains synergistic preparations, usually ropivacaine 2 mg per ml or levobupivacaine 1.5 mg per ml, epinephrine, ketorolac, and or clonidine. USG guided local infiltration is advocate nowadays, which provides excellent analgesia. Now, peripheral nerve block, there is little literature on peripheral nerve blocks for shoulder or elbow replacement compared to the lower limb replacement. Limited evidence shows that brachial plexus block offers superior analgesic effect compared with the systemic analgesics for shoulder and elbow replacement surgery. The systemic analgesics drugs which are used for pain relief, they are the NSAID, COX-2 inhibitors, acetaminophen, and anxiolytics, opioids which may be tramadol, fentanyl, remifentanil, morphine, and gabapentin. The NSAID should be used with caution in elderly patients who are at a risk of impaired renal function. COX-2 inhibitors are preferred over conventional NSAID in patients with increased risk of bleeding or gastric erosion. Oral or rectal paracetamol is recommended as a supplemental analgesia in all patients. Intravenous PCA with opioid may also be used. The side effects include nausea, vomiting, dizziness, pruritus, and urinary retention, which have to be treated accordingly. So conclude, I would say that arthroplasty demands the highest level of technical expertise in terms of regional blocks, maneuvering difficult spines and airway, along with a vast knowledge of geriatric medicine and coexisting diseases. With the introduction of daycare surgery, robot-assisted minimally invasive surgery, improved pain management techniques, newer rehabilitation protocols and guidelines in joint replacement surgery, the onus is now on the anesthesiologist to ensure a smooth sail for everyone. Thank you.